This video proposes vocal cord monitoring with flexible fiber optic laryngoscopy, FFL, during thyroid radiofrequency ablation, RFA. The recurrent laryngeal nerves, RLN, run posterior to thyroid lobes. These innervate all intrinsic larynx muscles, except for the cricothyroid muscle. Due to its small diameter, RLN cannot be detected by ultrasound. RLN is positioned in the so-called danger triangle, posterior and medial to thyroid lobe. Even if hydrodissection separating nerve from nodule is performed, thermal injury can still occur when large lesions abutting on this area are ablated. At this point, we can say that thermal injury to RLN during RFA may produce temporary or permanent vocal cord paralysis. Hydrodissection of danger triangle is the established technique for RLN protection during RFA. Many operators perform RFA under local anesthesia, monitoring RLN function by asking patients to produce sounds, which is an additional stress for the patients, especially for large lesions that require more time and general sedation. However, voice quality cannot be assessed by patients under general sedation. As FFL allows RLN assessment by visualizing vocal cord symmetrical movements during calm breathing, FFL monitoring during RFA may detect RLN dysfunction if vocal cord asymmetry is detected. Should vocal cord asymmetry appear, ENT specialist performing FFL advises RFA operator to immediately stop. In this video, we aim to report the advantages of using FFL during RFA carried out on a large thyroid nodule under general sedation. In the preoperative phase, the fibroscope is connected to a camera. Endoscopic images are visualized on a screen. This exam is performed in an ambulatory setting without anesthesia. The endoscope is inserted in a nostril and progressed through nasal cavity and pharynx until glottic plane is visible. In the endoscopic video, normal laryngeal movements can be observed with vocal cord adduction during phonation and abduction during breathing arts. In the general setup, a sterile field is prepared. In our operating room, all emergency facilities are available and you can see the various devices and preparations used in this procedure. The procedure is assisted by an anesthetist. Continuous ECG monitoring is performed. Midazolam 2.5 mg is administered. Propofol is infused by a pump, and eyes are protected by goggles. In the preliminary ultrasound examination, thyroid is assessed. Nodule diameters and volume are measured. The volume is about 34 mL. Vascularity and vital tissues are scanned by enhanced Doppler. There is blood flow into the nodule. After sedation with propofol, the endoscope is inserted through the nostril and progressed until the glottic plane is reached. With FFL monitoring, calm breathing can be observed. It's interesting to note that vocal cords move symmetrically during breathing acts. Local anesthesia by pericapsular injection of lidocaine 2% with 5% cold glucose solution is performed under ultrasound assistance using a 27-gauge Chiba needle. Anterior hydrodissection of the nodule from strap muscles and sternocleidomastoid muscle is obtained. Notice the anterior hydrodissection isolating thyroid nodule from muscle fascia. Ultrasound-guided posterior hydrodissection by the administration of 30 ml 5% cold glucose is then performed. Here you can see the needle tip posteriorly inserted. Anterior and posterior hydrodissections merge, thus separating nodule from vital neck structures. In the following phase, a radiofrequency needle electrode is inserted. The needle electrode is positioned in the inferior portion of nodule, adjacent to danger triangle, which has been isolated and protected by hydrodissection, which, more specifically, separates the nerve from the nodule. The initial generator setting starts at a low power of 30 watts. A peristaltic pump cools the electrode tip. After starting RFA, FFL shows calm breathing of sedated patient. Symmetric vocal cord movement during breathing acts demonstrate no RLN irritation. In order to visualize electroshaft, the ultrasound probe and needle must be perfectly aligned. Ablation starts at lower portion of nodule, close to danger zone, when hyperechoic gaseous microbubbles appear. This part of nodule is ablated first, before hydrodissection diminishes, which usually lasts about 15-20 minutes and is repeated if necessary. This technique permits a complete ablation of nodule. FFL monitoring during thyroid RFA reveals visualization of natural reflexive phenomena. In fact, a swallowing act by the patient can occasionally be observed during the procedure. After lower pole ablation, needle electrode is reinserted to ablate mid-portion and upper part of nodule. FFL is continuously monitored. The angle of insertion is adjusted in order to ablate the deep layers first, followed by ablation of superficial layers. The needle electrode is withdrawn when procedure is terminated. Thorough ablation of nodule is demonstrated by the complete absence of vascularization, as seen here with microvascular coral Doppler. A post-operative FFL is performed on conscious patient immediately after RFA in order to confirm normal vocal cord symmetric adduction during phonation and abduction during breathing. In conclusion, in this video we report for the first time the use of fiberoptic fibrolaryngoscopy for vocal cord monitoring during RFA procedure. FFL may be an additional technique to hydrodissection to prevent RLN thermal injury during RFA. FFL is easily performed by ENT specialists and well tolerated by patient. This is a medical advance in recurrent laryngeal nerve protection during RFA, especially indicated for large thyroid nodule ablation and for professional voice users such as singers, actors, and broadcast personalities.